Okay. For Chair Secretary Session Money, I'll hand it over to you.
Great. Well, thank you everyone for joining today. Certainly there is a lot going on, and we continue to appreciate all of your engagement as we are navigating some pretty challenging times to make sure that we are, continuing to manage the health benefit exchange to really enable people to stay covered. So I think the first order of business is an approval of the minutes. So I will ask, do I have someone to forward the motion?
So moved.
Do I have a second?
Second, if Marie was first.
Great. All those in favor?
Aye.
Everyone raise your hand and then Cynthia will record your hand raised and let everyone know.
Okay, thank you.
Great. So the minutes have been approved. So I think next, Cynthia, are you going to be talking about the public comment period?
Nobody registered for this month.
Okay. Then we can move to board committee reports. So I will turn it over to first the Standing Advisory Committee.
Thank you. Happy New Year. We're seeing a transition in the Standing Advisory Committee. And so Mark's term, co-chair, who's been serving the past 3 years, and 9 other members are concluding. And so we're actively recruiting new members for 2026, focusing on consumer advocates, public health professionals, and particularly Western Maryland representation. And during the more recent meeting, we talked a little bit about some of the federal discussions that's been having, upcoming changes, a lot of what we'll touch upon today as well. And we talked about the 2026 Value Plan Work Group and had some recommendations for 2027 plan designs. And the new small business portal is operational. And so we talked a little bit about that and just continuing outreach initiatives, particularly related to small business. And we're actively supporting consumers through recent webinars on navigating the 2026 marketplace changes, healthcare options for job seekers, along with upcoming post-enrollment options and webinars to how to use the platform. And then lastly, 2 more things actually. During our more recent meeting, MIA presented on health coverage assistance team, HCAT, and advisories published prior to the open enrollment. Specifically just around, we talked a little bit about against fake health insurance sites and junk insurance plans. And then lastly, just with the upcoming changes to immigrant eligibility, well, they're here at the time they were upcoming, but we talked a bit about that, and that spent a lot of time in our discussion around the marketplace and Medicaid coverage. So I'll pause there to see if folks have any questions.
Could you say again where the I missed some of what you were saying about the non-ACA plans, what was that, a webinar for consumers, or?
Are you talking about for the small business? Like the consumer education
I think
event?
you called it junk plans. I call it junk plans, but I forget.
Oh, yeah, consumer protection. So MIA had presented their health coverage assistance team presented, and they talked a little bit about just prior to open enrollment, some of the things that they've been seeing and warning against fake insurance sites and junk insurance plans. And so we talked a little bit about that just in the undercurrent of consumer protection.
Okay, thank you.
Yeah, no worries. Thank you.
Just on that topic, for board members' awareness, we actually have some departmental legislation to help address the fraudulent plan issue. It's a bill that allows us to hold TPAs accountable for violations of the insurance article rather than just the TPA section of the statute. One of the challenges we're having in enforcement is we can go after brokers in these situations, but our authority gets more limited. And so that'll be a big help to us. I'll share that in the chat, but just it's very important legislation that related to this issue that might not be clear on the surface.
Thank you for that add. Ken, do you have your hand up?
You did not.
Oh, okay. Just making sure you didn't have a question.
And it is up if you want to put it down.
Oh, I'm sorry. Yeah.
Great. Well, if there are no other questions, then we can turn to the Finance Committee. Maria, are you on? Maybe you're talking on mute.
I am on, Michelle, and I did attend the meeting for the finance, but I did not drop any points. I'm sorry. Being new to this, I forgot that I'm reporting. Maybe Tony can help me out. I was at the meeting present and stuff, but do not have, did not write up my points. I apologize. So Tony, I don't know if you can help with a brief.
No problem.
Thank you. Appreciate that.
Sure, no problem. Basically, first we went over the financials, and at the end of we showed at the end of October, and at the end of October, for state purposes, we were over budget by $32,000. And actually, what happened is I sent everybody in preparation for this board meeting all the stuff that I sent the finance committee because they were so close together. So I just went over the areas of that were high, the areas that I mentioned something were payroll, call center, fulfillment, and then the overall IT expenses. And after I reviewed that, which, as I said, you all have the same presentation and the same narrative in the board packet that Scott reviewed compliance. And I don't know if Scott, are you on the call? Scott or Saika?
Yes,
Okay.
I'm on the call, Tony, and I can give a brief on the compliance audit and privacy updates. So during the Audit and Finance Committee, we provided various updates regarding our privacy program, which covered our trending quarter over quarter of privacy incidents that we see, and any upward or downward trending. We did report a fairly stable quarter over quarter and year over year trending of privacy incidents, which we consider to be very low. We also went over privacy program highlights, including our memorandums of understanding and our non-exchange entity agreements. We then turned our focus over to corrective action and audit activities in anticipation of ongoing and upcoming audits, including the Office of Legislative Audits that is due to begin in the middle of this calendar year. And then we turned our focus finally over to internal reviews, which are ongoing and are conducted on an annual basis by our department, where we look at the controls and compliance of individual departments across MHBE to test, policy adherence, regulation adherence, and suggest process improvements. So that covers compliance, audit, and privacy section of our committee presentation. Thank you all.
Great, thank you. So I think with that, Michelle, I'll turn it over to you.
Thank you so much. Well, the big news is we have completed another open enrollment cycle. So that's really good. And the news is interesting. for this year. So I'll go through it all, but it's going to be, I tell everyone, it's a year you have to dig a little deeper. We're hearing out of the federal government that, oh, enrollments are up, enrollment is fine. Those that lost enrollment were really the fraudulent people. And so that's a narrative that is being put out. And we saw that for our enrollments, we are up 3% for our enrollments. So we ended with 255,612 enrollees. That's the best number that we have ever had. So that's terrific. And we really thought we were going to see significant losses. So that's really the good news. What we have to keep in mind is that we started at a higher point with our renewals because last year was the public health emergency unwind. And so we started at a higher level, which was really good. And then the bad news is our total enrollments are down. And our new enrollments, we call the initial enrollments, are down. And so those, again, a measure of who's coming in and who's enrolling. And then, of course, our disenrollments are up. Now, where we, pardon me, when we start to dig down deeper into the layers, we look at, all right, well, what happened with those with financial assistance? What do we see for those without financial assistance? And for consumers that enrolled without financial assistance, that increased 43%. So we have over 83,000 consumers that enroll without assistance. Now we know automatically that we had a large population, the under 100 federal poverty level, which are lawfully present immigrants that could get premium taxes that premium tax credits that no longer could. We knew they were in that population. So they were enrolled without assistance. Then we look at those that were enrolled with federal tax credits, and we saw that that is down 9%. Those that normally would have gotten the federal tax credits. Again, that's the enhanced premium tax credits that are lost. And so those enrollees, particularly those over 400% of FPL, which no longer were eligible for those any tax credits, they were impacted. We saw that those that enroll with young adult subsidy assistance still continues to be a solid program. Again, we know if you make insurance affordable, people want that insurance. We saw an increase in 9% of that. But the big story of this, and I think this is the big story that nationally, at least the state marketplaces will be telling, is that people want health insurance. They'll do whatever they can to keep their health insurance. And that means buying down to less generous product offerings and taking on more financial risk for their families. So we saw a significant shift in buying, what we call bowing down. People that bought down from a gold plan. We had nearly 5,000 people that bought down from a gold plan to a bronze plan. To put that in context, that means that family went from having, that individual from having a $1,000 deductible to having a $10,000 deductible. So of that population, the largest percent affected, two categories, those over 400%, which again, we could not provide any state premium assistance for them, and then those over age 55. And so we have pre-retirees that are, again, know they need coverage, but they're going to be taking on additional financial burden. The next largest category we saw was the shift from gold to silver. And again, the largest age population we saw in that are those that are over age 55. So just as we had suspected, those that are at the higher income levels that the state premium assistance program could not assist have either dropped out of coverage or have purchased less robust coverage. And those that are over age 55 pre-retirees, many folks that, especially under 100% FPL, that haven't worked long enough to qualify for Medicare and could buy through the exchange, and if they were an immigrant, had the 5-year bar, they now cannot afford that without the financial assistance. So more financial burden for the consumers. Maryland did fare much better than many states because of the state premium assistance program, but we know that will not be able to be continued indefinitely. That's tied to the reinsurance program, which is going away at the end of 2028. So we'll have to be having some, and we already are having those discussions, looking, and again, so proud to be from Maryland because we're working with Department of Health, Department of Human Services, Maryland Healthcare Commission, Health Services Cost Review Commission, the Governor's Office, looking holistically at knowing not only what the marketplace impacts are, but what's going to happen with the other OBA impacts, how that is going to affect our providers, not seeing patients, not getting paid, impact to the hospital system, the increased wait times, all of these that play into the well-being, health and well-being of Marylanders, and we're going to have a unified approach as a state and how we look at what we do for all of the health ecosystem and how we fund all the areas that are in need. And there will probably be a lot of difficult decisions to make. But again, grateful that we're not doing it in a silo, that we're doing it collectively and with the Maryland Insurance Administration as well. So that's it on open enrollment. Moving into federal government, there still is a little bit of chatter about, well, will Congress do anything on the tax credits before the end of the month? No one in my circles has any hope that anything would occur. But again, if those tax credits ever got continued, we would make it happen. We would do whatever we needed to do to really bring more affordability to Marylanders. We are also waiting on the 2027 notice of benefit and payment parameters from CMS. This is where they outline guardrails and rules for the next 2027 plan year. It's late at this time. Usually we get this in December or by early January, so it's late. We do expect that there will be items in there that affect and perhaps even further impede enrollment, so we'll keep the board posted on that. With the One Big Beautiful Bill Act implementation, I talked about the collaborative work we're doing with the other state agencies. I just literally got off the call or the briefing, all those agencies, well, DHS, MDH, MD Benefits, and the exchange were briefing the Appropriations Committee. So just finished that. The next big impact for the marketplace will be January 1, 2027, which are some more immigrant impacts. There will be some Medicaid impacts on immigration coming October 1st, 2026. And then our open enrollment will change for next plan year for the marketplace, and it will lose 2 weeks, the January 2 weeks. And then the next big targets are for January 1st, 2027, the ACA expansion as adults redeterminations moving from 12 months every 6 months, and then implementing the work requirements. So that's kind of the timeline of what we're seeing ahead of us. State updates tomorrow. The governor's budget will be made public, and so that we'll be able to talk more about that. That's tomorrow. 2026 legislative session has begun. We have our meetings with legislators as we do every year. We only have one departmental bill this year, and it's just a technical update on I think the pregnancy special enrollment period. So there's nothing big, but there will be a lot of larger discussions about moving forward with all the threats around us. Regarding our agency, we have one open vacancy that's in the process of being filled, the replacement of the Director of Policy and Plan Management. The application process is closed. We're now in the interview stage. And then moving out of open enrollment, we move right into preparing for all the work I just talked about under OBA, and slash HR1 and preparing already for the next round of carrier plans and rates and general open enrollment efforts as we move forward. And then finally, I did send materials to the board to add one additional board meeting to our agenda for 2026, which would be June 15th, and making that the all-day board leadership planning session. So it would be separate from doing it in July, where we actually do that, and then a board meeting, and it makes for a very busy and rushed day. So with the board's happy to discuss that. The thinking behind that is that the board and the leadership team would have one day to really have a planning session and be able to spend time together, and especially for board members who don't get to see each other often. In the future, we'd love to make that, not this year, but maybe next year, an overnight where we could, do a evening dinner beforehand and such. So we do have a motion on the agenda to, if the board so chooses, to add that day. If someone would like to, I'll hand it back to you on that, on discussion around adding that additional board date. And with that, I'll stop and happy to answer any questions.
Yeah, I think one thing, thank you, Michelle, for your comments. I think the one thing that I would add is that certainly we have to see what happens now with the binder payment, right? If we have people who were auto re-enrolled who don't realize the impact that has happened to their premiums, we could see a drop. And I think that similar to the cuts that you did on looking at age, income status, I think that will be very helpful for us with this binder payment dynamic that we're going to be seeing as well.
And even just the renewal payments, because there are grace periods. So that's
Yep.
why we don't know until really April.
Yep. I see, Joanne, you have your hand up.
Yeah, I do want to thank you for those breakdowns about the different groups affected in different ways, over 55 and over 400%. That's really helpful detail, I think, for us to understand how this plays out. I'm just curious, for the people who were previously in silver and are now buying bronze, is there any way to know if some of those folks would have been eligible for the cost sharing reduction plans and are giving up that extra help? Or do we have guardrails in place to sort of guide them so they really understand that stepping down to bronze is a big impact for them, especially?
We do have the data to look at. I did not stratify it like in that with a cost share reduction for the silver, but we certainly absolutely can look at that, and we do have the data for it.
And do we have any feedback like from the CEs or the brokers about some people, if they had those conversations about, this is a lower premium, but in fact, you're going to be getting a much bigger deductible? I mean, do we have any sort of color commentary from those interactions?
I do not at this moment, no.
Okay, thanks.
I'll make a note of that. We'll get both of those to report back up.
Just to follow up on that point a little bit, small sample size, not scientific, but in my conversations in the outside world with folks who are wrestling about coverage, they were pretty aware of the trade-offs and really wrestling with them when making decisions about plan purchases this year.
Any other questions or comments? Okay, then can I have someone for a motion to approve the 2026 board meeting dates with the additional date that that Michelle mentioned?
I move. So move.
I think there was a second and maybe even a third in there.
I'll do second if the first was.
All those in favor?
Aye. Okay, thank you.
Great. Moving on to small business plan limits. Johanna, I'll turn it over to you. Johanna, are
thank
you on mute?
Yes, I'm here.
Okay.
All right, thank you. Next slide. All right, so the background here, we are proposing to update regulations that set our plan limits per metal tier in the small group market beginning plan year 2027, so January 1, 2027. Excuse me. We're proposing to adjust our current plan limit, which is 4 plans per metal level per licensed insurer, to 8 plans per metal level per insurance holding company. So the change here is both at the number of plans per metal level and at the entity at which we're setting the limit. So we're moving up a level from the individual licensed issuer to the parent holding company. The reason for this is that we have some carriers that have multiple licensed issuers. You can see, for example, United has 3 entities under the United umbrella. We have other carriers that just have 1 licensed entity. So in a long discussion with our Small Business Programs Advisory Committee about how to set the right limits on the small business market, we determined that moving up a level to the holding company to set the limit makes more sense and provides more of an equal playing field. As you can see from the chart, we don't have any overall parent entities that offer more than 8 plans per metal tier currently, even across all of their licensed entities. So no carrier would have to cut a plan in order to comply with these limits, but it would allow some carriers to offer additional plans at each metal level. We overall have these limits to reduce choice overload and manage kind of a reasonable number of plans per metal level that provides enough opportunity for differentiation and choice to consumers without having an excessive number of options that can ultimately make it more difficult to shop. On the individual side, we have a limit of 3 plans per metal level, and we're still applying that at the licensed issuer level, but it's not quite the same market dynamics there. And then we also anticipate that on the small business side, businesses are much more likely to work with a broker and much less likely to do self-service. And so choice overload isn't quite the same level of concern as it is on the individual side because they have that personalized assistance. And we've gotten a lot of feedback that as we are expanding our offerings on small business through our new small business enrollment platform, there are no limits to plan offerings outside the exchange. And so there's many more plan choices outside the exchange. And to help put the exchange's small business platform on a more competitive footing with the off-exchange market, it would be helpful to have more choice. So that's the background here on the change. And then in addition, we're proposing to add a meaningful difference standard for small group plans. We're mirroring federal language around this, and the goal is to give us additional regulatory authority to ensure that if a carrier does offer up to 8 plans, they are significantly different and provide meaningful choice to consumers. So we will have that authority if we need it. Next slide. We talked to the MIA, as I mentioned, our Small Business Program Advisory Committee and our Standing Advisory Committee as we were thinking about this proposal and drafting it. We had an informal preliminary stakeholder comment period in December, and we got 1 comment expressing support for the proposal. So this has been extensively discussed with stakeholders already. Next slide. Here's just the proposed language itself. I won't dwell on it, but it was in the board materials provided as well as on this slide. And next slide. So with the boards, if the board votes today to approve this proposed regulation, it will be published in the Maryland Register, which will initiate a formal 30-day public comment period. And we anticipate bringing it back to the board to vote on as a final regulation at the April board meeting, with the regulations effective in May, and that tees us up nicely for the plan filing process for 2027. Next slide. So here's the motion. I'm happy to take any questions on this.
Joanne?
Yeah. Thank you for this. I was trying to find, can you say a little bit more about the meaningful difference standard? One, will it apply on and off exchange? Because you were talking about the leveling the playing field. And then secondly, can you tell us a little bit more about how that is actually defined? I lost track of that. And I believe at some points, or at least for the individual market, folks thought that it could have been made stronger to really make sure those differences are meaningful and evident to consumers to help them with their shopping.
Yes, could we go back a slide or two, Cynthia? I think to the language itself in the proposed regulation. One more. There we go. Oh, no, forward one. There we go. So I think we in 3A here, we've got the meaningful difference standard language. So it's and this applies only on exchange. So the exchange doesn't have authority over off exchange plans generally. So we're only proposing this for on exchange. And as I mentioned, we pulled from federal language and said the exchange must meaningfully differentiate these plans in terms of benefits, network, prescription drugs, or some combination. And then we go on to give some examples of what would be considered meaningfully different. I think, you know, we felt most comfortable just pulling the federal language. We do have other authority elsewhere that talks about the exchange can decline to certify a plan if we don't think it's in the best interest of our consumers. So we're not wholly reliant on this language to make our certification decisions, but we wanted to include it to kind of bulk that up.
But there wasn't, I can't remember if this was proposed and rejected at some point, but like, you know, a difference of at least, I don't know, $50 or something in cost sharing. There was some more granularity there than this language. Does that exist anywhere?
We didn't see that in the federal language, but I do feel comfortable that this gives us flexibility to take a look at these plans, and there won't be so many per carrier that we can't really scan them and assess at a high level. Do they look different from network benefit
Okay, thank you.
standpoints?
Well, I guess I can call on myself. But you know, in some ways, building on Joanne's comment, I think one thing I was wondering about is the reason for doing this was it felt among the small business community that they didn't have enough options and variation as it was. Because then the counter is to what Joanne was getting at, like, are you creating confusion if you have like lots of different things, but there isn't actually like that meaningful difference?
So yes, the feedback we got was that there was too limited a set of options on the small business side of the exchange, and that different stakeholders, carriers, brokers, employers wanted more diversity of options similar to what they have on the off exchange side, which in the off exchange market, there's many more plans than we will have on exchange. So it's still not going to be the full breadth of off exchange, but it will be more selection.
Ken?
As a small business owner who has encountered many difficulties with aided plans throughout my 40-year history in business, is there an overall goal to kind of fill in some gaps with small business plans for people who are impacted in the individual marketplace?
I would say that we are looking at both markets holistically in partnership with the MIA and how we work towards affordability for individuals between the small group and individual markets. We do have reinsurance on the individual side and the different financial assistance programs, both federal and state. So there are a lot of reasons that coverage may be more affordable on the individual side. But we want to support the small business side as well, because we know that that's important for employers as a recruitment tool, and that they also want to have the option to contribute to their employees' premiums. So I think there's different benefits across the two markets.
Thank you.
Okay, any other questions? Okay, I think then, do I have a motion to approve the small business plan limits, proposed regulations as presented, and authorized MHBE to submit them to the Division of State Documents for publication in the Maryland Register?
So moved.
A second?
Second.
Those in favor? Oh, okay. Those in favor?
Okay, thank you.
Any opposed? Okay. Next agenda item is Johanna again, 2027 Plan Certification Standards. And we are 2 minutes ahead of schedule.
Okay, I'll try to keep it going. All right, so as you all know, the exchange, the board, sets plan certification standards for plans sold through Maryland Health Connection, which encompasses plan design, operational requirements, and other requirements. Examples of previous plan certification standards, including requiring issuers to have NCQA health equity accreditation, and requiring dental carriers to offer the Pay Now functionality, which allows individuals to end their enrollment process by clicking through a link to the carrier's website and paying their first month's premium to effectuate their coverage. Additionally, we've had our value plan standards, which the board has set annually from 2020 to the present day. Value plan designs are our standardized plan designs. They standardize the cost sharing among plans. Benefits are largely already standardized among plans, but they standardize cost sharing. And we require carriers to offer one value plan at the bronze, silver, and gold medal level. And then going back to our discussion of plan limits, carriers on the individual market side can offer 2 plans of their own design at each medal level. So one value plan, up to 2 of their own design, but they have to offer the value plan. We have leveraged the value plan design as a policy tool with several goals. One is to support affordability and access to care. And we do that by decisions such as prioritizing co-pays over co-insurance, because we've gotten, and many individuals have gotten feedback that co-pays are easier to predict and more understandable to consumers than co-insurance. We also try to prioritize having services available pre-deductible with that copay so that individuals don't have to meet the deductible for commonly used services. Value plans also simplify plan choice. They give consumers the ability to compare the same plan design across insurers so that they're not shopping on cost sharing, but instead can look at premium, network, and quality. And they are also an opportunity to promote health equity. Specifically, we've done that by making commonly used preventive care services for diabetics free, and other diabetic tools and services available at zero cost sharing to the individual. Next slide. So for the timeline, we will be asking you to vote on our proposed 2027 plan certification standards today, and that will be followed by a formal public comment period. We are also waiting for the federal actuarial value calculator to be released. That will govern the ultimate design of our value plans because that sets cost sharing limits at each metal level, and we have to make sure that our plan designs are permitted under the AV calculator. So we will make adjustments to these plan designs as needed, and depending on how extensive those adjustments are, we will certainly regardless consult with our stakeholder work group, and then we'll consider whether any additional public consultation is needed. But our hope is that we'll be able to bring a final set of plan certification standards to the board for consideration in February. That may get pushed back because it's already January 20th and we don't have the AV calculator, so we're really dependent on the feds for this timeline. And these standards will be in effect for plan year 2027. So our only plan certification standard that we're bringing forward for 2027, our only new one, is the updated value plan standards. And behind this timeline, we had extensive engagement with a stakeholder work group that includes insurers, navigators, brokers, and consumer advocates to come up with recommendations for 2027. And then we also shared this with the Standing Advisory Committee. So it has been vetted through several rounds of stakeholder engagement. Next slide. So the proposal itself is not a significant change. We're proposing to maintain the 2026 cost sharing structure for 2027. And in the appendix slides, you can see what that looks like, the deductibles and the cost sharing for each service. The change that we're proposing relates to the diabetes coverage requirement. We're proposing that carriers cover at least one continuous glucose monitor, also known as a CGM, at $0 to the enrollee, and require carriers to host an easy to understand, transparent, and searchable document on their website to provide information on the services that are available to diabetics for $0 and instructions on how to access and qualify for the CGM. Next slide. This slide goes into some additional recommendations from the work group related to actions to be undertaken by MHBE, including making information on these diabetes benefits more accessible on Maryland Health Connection to our consumers, doing some consumer testing on the value plan name. We're interested in figuring out if that name is really conveying what we want to consumers and considering alternatives in the future. And then also collecting some data on utilization and denial related to these diabetes benefits to identify any consumer challenges to accessing those. And we'll be partnering and consulting with our sister state agencies to make sure that we're not duplicating work as we consider how to move forward with that recommendation. Next slide. And happy to take any questions, and the appendix slides have a lot more information as well.
Doug?
So this is great. As a primary care doctor who just sees a lot of patients with diabetes, it is fantastic to have access to $0 cost sharing for CGMs that improve quality of care, diabetes treatment. One just I put on my clinician hat for a second. I saw that it's with a diabetes diagnosis. So there's two different kinds of like diabetes mellitus and diabetes insipidus. It's diabetes mellitus where managing glucose is a thing, and diabetes insipidus, it's not a thing. And so I just say that because in the documents, it just says with the diabetes diagnosis, and it's relevant for some people with diabetes, but not all. So I just wanted to make that clinical point that it might be helpful to differentiate. Yep.
We'll be happy to follow up with you to make sure that we're accurately capturing that.
Ken?
Not a question, just a comment. I wanted to offer my congratulations and kudos to the committee. It was a very broad-based, diverse group of healthcare professionals that engaged in quite robust discussions. Also particularly want to thank Becca Lane. Becca was quite the leader in making sure that everybody was engaged and all their time and comments were validated.
Thank you, Ken. Yes, very grateful for Becca and her leadership of that work group.
Any other questions, comments? Okay, do I have a motion?
I can make the motion.
Great, a second?
A second.
Second.
Those in favor?
Aye. Thank you.
Any opposed? Okay, the ayes have it. Next on the agenda is MHC for small business update. So I will turn it over to Mimi.
So much. Hello, everyone. Thank you for having me back here. I'm here to discuss the trends, the challenges and opportunities in Maryland small business, in the Maryland small business landscape. And so in this slide, in Maryland, there's close to 697,000 small businesses, and there are 1.2 million people employed by these small businesses, and 39.5 of small employers offer an employer-sponsored insurance compared to about 54% in large employers. That's more than 50. Under 50 is considered small group, and over 50 is mid and large group segments. And in 2025, we have about 203,000 enrolled in 2025, which is a continuing, but kind of on trend with what we've been seeing in the last few years, which is a continual decline compared to 248,000 in 2022, according to the Maryland Insurance Administration. Next slide. Thank you. Overall market challenges, primary concern is costs, the rising nature of the premiums, and it is a primary concern for small businesses, both here in Maryland and nationally. Inflation has played a huge role in this as cost of goods and services increases, so do healthcare costs, such as pharmaceuticals, medical services. And small businesses often face budget constraints, and this is across all markets, right? We're seeing this regardless of what, whether it's small business or individual or large group. And employers also find it difficult to find clear, unbiased information to guide their decision-making when selecting a health plan. And lastly, small businesses find it challenging to manage an employer-sponsored plan due to limited resources. Next slide. Maryland Health Connection for Small Business is the state's marketplace designed for businesses, for small businesses. And employers can choose from 3 coverage models: employee choice, employer choice, and a single plan. And what you see in that image there on the right side is the design for the newly launched enrollment portal that was just launched in September. And one unique option that we offer is called employee choice, which allows employers to select up to 2 consecutive metal tiers. And that allows them to offer all plans from any insurance carrier within those selected metal tiers. And another feature we provide is the single invoice to the employer, which was a tremendous hurdle that we had to get over when we had the direct to carrier model, where employers were receiving multiple invoices when they signed up for employee choice. So this streamlines the enrollment and the premium aggregation, and reduces the administrative burden on the employer and the employees. We've always allowed small businesses to see if they're eligible for the small business tax credit, and this feature also sets us apart from the off-exchange market, as our platform is the only place businesses can get their determination and see if they can purchase coverage from Maryland Health Connection for small business, and they can take advantage of that tax credit by filing the IRS Form 8941 with their business taxes. Next slide, please. So as I mentioned just a few minutes ago, we launched our new enrollment portal back in the fall of 2025. And so this small business program is designed to help MHBE's mission to reduce the Maryland uninsured rate. Our sweet spot is the smallest groups with fewer than 10 employees. We also expect to enroll about 10,000 covered lives, and I'll show you how we expect to get there in the next few slides, but we expect to have about 10,000 within the first 5 years post-launch. And we also want to fulfill our statutory mandate to serve the small business market. And we plan to launch our full marketing plan in the spring of 2026. So that's coming up in a few months. And the feedback we've received from brokers and employers so far is that users appreciate the modern look and simplicity of the navigation of this new portal. And that's a quote that we received from one of our top broker, Eugene Poole. All right, let's get to this next slide. So this chart shows the following total group counts for each month by effective date. So in our initial launch, in the first set of groups came in November, and we had about 9 groups, and then in December about 8 groups, but then in January we jumped to about 37 groups, and in February, which is coming up next month, we currently have about 19 groups, and that's a total of about 73 groups that we have that are active in the system just in Q4. And then let's look at the covered lives in the next slide, please. Thank you. So the chart displays the count of covered lives for each month. Again, November, we had about 90 total covered lives, and this includes the employee, spouse, and dependents. So that's what we're counting here. And December, we're looking at 40, and January, 294. That was our peak time. It's very common for this time of the year to have a high enrollment in Q4, especially for January 1. And in February, 141 covered lives, and that's totaling about 465. So if we do this number, that's 465 times 5, that gets us about halfway there. And then the rest of the quarters, if we average even at halfway point, you know, we'll fare off pretty well. And I think we'll be on target to hit that 10,000 mark. So we're very excited about this, and looking forward to, you know, seeing this come to fruition. All right, next slide. So one of the programs that we also launched in addition to this portal is a small business outreach and education program. And this would be a 3-step program for employers to receive a seal that shows their support for health coverage for their employees. And step 1, we have the videos posted on that website. So step 1 would be watching those 2 short 7-minute videos on our website, and that educates the employer on the basics of health insurance, like health coverage options, and whether connecting their employees with the individual market, if that's what they need to do, if they qualify for any subsidies versus establishing an ICHRA plan, or whether, you know, that would be technically off exchange for now, but their employees and their families could enroll in the individual market using the employer allowance. And if the employer can afford it, they can purchase the traditional small group plan on our portal. And so the video educates them about the employer and employee choice options and the healthcare tax credit that I mentioned earlier as well. And after completing those videos, the employer will need to find a broker to present to the employer and his employees. So typically it could be virtual or in person. And at that meeting, the broker is expected to provide a more in-depth presentation about coverage options, and like the ones that I talked about. And if the group is ready to enroll, the broker will assist the group with enrollment. In step 3, the broker will certify that the group has been presented to and signed up for coverage. And once MHBE receives this attestation, we will issue an MHC for Small Business seal that says we offer health coverage to the business. So they can use this as a marketing tool for their website. They can post it. We recently had a discussion with marketing about posting that seal on their website or on their social media, and we'll provide them the social media links to use and hashtags to use, and it's I think it's a great tool for them to have, and that they offer the health insurance, which is a top ask from employers, is, you know, to be able to provide affordable health insurance as a recruitment tool, as Johanna said earlier. So this program is just launched, so we're still looking at the efficacy of it and seeing if it's, you know, working. And for the existing businesses that we've signed up that I showed you earlier, for those 73 businesses, they automatically get that seal for signing up. So that's also another benefit that we have as well. All right, next slide, please. So there's a lot of opportunity and innovation in the market space, in the small business marketplace. We're looking at implementing IPRAS into Maryland Health Connection for Small Business. And we will continue to enhance and improve the MHC for Small Business enhanced enrollment portal. And one of the ways we're doing that is by increasing the number of plans, as Johanna mentioned earlier, and you all graciously approved. And that helps us maintain the competitive edge in this market space compared to the off-exchange market as well. And we, you know, always want to look at increasing affordability to small businesses through legislative channels and expand the outreach and education program by the lowest insured areas, such as, you know, gig economy workers, childcare providers, and so on. So next slide, please. So this is a timeline of the marketing plan beginning September 1st through October 15th. The awareness campaign with different email marketings and events and partner stakeholder newsletters and events. And then the outreach and program that I talked about, we're using that as a marketing ploy as well. And then January through March, webinars, conferences, and events, and then a full launch of the targeted paid ad campaigns and digital and social media press release to the media to, you know, garner media attention in the spring. So we're looking forward to all of that. We do have some appendix items, which includes information on the next few slides. Just includes information about the tax credit if you'd like to look at that down the line, but I won't get into it. And there's also some slides about eligibility and market rules on our platform, and some other items about, you know, marketing and outreach events, and, you know, which state agencies and nonprofits we're out speaking to and engaging with. And our resources and fact sheets from the marketing department. So thank you all for your time. And do you have any questions for me?
Amy, can I ask you a question? Has the
Of course.
board seen the portal? Did you do that demonstration before? I can't recall.
We have not actually provided a demo. Maybe that could be a nice addition for the next board meeting.
We should definitely at least yeah, do a little quick demo at some point in time. So it's pretty cool.
Thank you so much. Will do. Happy to come back anytime you guys need me. Any other questions? Yes, I believe there's more questions.
Yeah, Ken has a
It's-
question.
Yeah, Mimi, are all of the current carriers that offer small business plans, are they in the mix for the opportunities here?
So we have about 3 carriers participating in the small business market space. So we have Kaiser, CareFirst, and United Healthcare. Aetna left both the individual and small group market space in about 15 states last about a year ago, maybe less than a year ago. But they all do participate. They offer medical plans. They do not offer ancillary products in the small group market. I hope that answers your question.
Yeah, one follow-up though. Are you aware that there are a number of plans, small business plans, that do not allow the business owner to enroll?
So there are some rules around that. The business owner by himself cannot enroll and the owner cannot enroll himself, and family members cannot enroll by themselves. So they need one common law employee in order to sign up. But that common law employee could end up waiving their coverage, and then the employer could still sign up.
Okay, thank you.
You're welcome.
Just to,
Sorry,
make
Marie,
clear-
I keep being on mute when you're raising your hand.
Oh,
to-
it's
I'm
okay.
unable
You
to
know,
call on
I'm
you.
pushy, Madam Secretary. I'll just talk. I, so I think under that example, though, that small employer, if they don't have that one common law employee, they have access to our individual market. Is that correct?
That's
That is.
absolutely correct.
Okay.
Yeah. And that's definitely in the training that we provide to brokers and, yeah. Any other questions for me?
Okay, thank you, Mimi.
Thank you.
I think next up are procurements. So I'll turn it over to the team.
Cheryl, would you like to take it?
Sorry about that. Yeah. Good afternoon, everyone. Happy New Year. This is Cheryl from Procurement, and we will be setting the option renewal for Salesforce. Thank you.
Good afternoon, Madam Secretary, members of the board. Today I'm joined by our procurement officer, Cheryl Green. We would like to present to the board for approval to renew the Salesforce licenses. This is a renewal to ensure we maintain continuity of Salesforce operations. It's a business critical function across our organization as well. First, I will talk through what Salesforce supports in our environment and the license and cost comparison between 25 and 26, and the specific license strategy that we employ to reduce some costs, and how the renewal is funded within the IT budget. And then I'll hand it over to Cheryl for providing more details on the procurement itself. Salesforce is not a single application for MHBE. It's the platform we use to manage several business critical functions. And in 2026, we will be enhancing and integrating more applications into this ecosystem. At the core, Salesforce is our CRM, Customer Resource Management Foundation, but it also supports key operational applications such as time management, producer operations, and several other internal applications as well. It also connects the call center's computer telephony integration, CTI system, and live chat integration. So calls and chats can be captured, accounted, and reported for operational metrics. Beyond service channels, Salesforce also supports several operational integrations and control processes, including carrier data integration systems, our appeals portal, and our inventory and asset management systems as well. We also use it for automating ticket escalation management processes, so urgent and critical issues are routed quickly and tracked end to end within the system. Finally, not the least, we are positioning the platform for eventual AI adoption, and we have recently implemented an AI agent in the call center. When consumer calls the call center, certain technical requests such as password resets or looking at the consumer's case status can be automatically responded through AI. So this platform also integrates these functions as well. Next slide, please. This slide shows a side-by-side comparison of our Salesforce license quantities and costs between 2025 and estimated 2026 renewal. The headline number is a reduction of about $36,000 in total between these 2 years. The biggest driver is the reduction in our highest cost category, Service Cloud Enterprise Edition and Government Cloud, which decreases some 425 licenses from that to 384, which kind of reduced around $140,000 or so. And also there are some incremental license cost increases across other segments, resulting in overall cost saving between these 2 years. Bottom line, we migrated from certain types of licenses that are expensive to certain types of so-called enterprise flex uses license that are cost, at least in terms of cost, it was less expensive, but in terms of our purposes, it's very tied to our usage also. So this is an annual exercise that we do for all of our software licenses. We look into the details of usage and any improvements, any new additional standards in the market that could improve the performance as well as reduce the cost for the agencies. This is an annual exercise for us in this regard. The next slide, please. This is an explanation of the specific 2 items that kind of contain the cost for us this year. The first line item is a quantity of 49. These licenses support users who only need internal Salesforce apps, allowing them to move off from the higher cost Service Cloud licenses while still retaining the access required for their job functions. The second line item of 29 licenses talk about the capability of it providing API access for reporting, automation, and backups. This is type of a technical utilization of a different type of licenses, thereby eliminating the higher cost licenses. The key takeaway in the slide is that our license renewal is targeted, practical cost control, right sizing the license or employee to reduce cost as much as possible. As you may already know, the license cost for Salesforce and other cloud-based applications are anywhere from 6% to 12% increase year over year. But we are trying to contain the cost within our ecosystem here. Next slide, please. This slide answers the funding question directly. IT software is federally funded at a rate of 66% overall of the total cost. And this funding has already been allocated in the FY26 IT budget. So from a budget standpoint point of view, this is planned spend under the standard federal and state match model. The year-over-year difference, as you can see, is a total reduction of around $36,000 with state savings around $12,000 this year. I will pause here and hand it over to Cheryl to provide procurement details.
Thank you, Venkat. Next slide, please. Okay, procurement summary. This license will be for 1 year, starting March the 2nd, 2026 to March 1st, 2027. Our procurement method was the intergovernmental corporate purchasing agreement task order request. The approved seller is Carosoft. The cost of the license is $1.522435. We rounded that up. And cost of license for 2026 was below that at $1.486611. Next slide, please. Quotes received from seller on August the 25th, 2025. Approval from CMS was received on December 1st. The board approved request was on today, January the 20th, 2026. And after the meeting, we hope to have the task order done by the 22nd. And the procurement process should be completed by the 31st of this year, January. Next slide, please. MHBE requests the board to approve the exercise the intergovernmental corporate purchasing agreement, second option, year renewal with Carousel Technologies Corporations for the period from April 1, 2026 to April 1, 2027, and award contract to Carousel Technology Corporation in the amount of $1,486,611.38 with a federal participation of $981,163.51 and a state participation of $505,447.87 to procure the Salesforce license for the period of March. It's a contradiction in those numbers. March the 2nd, 2026 to March 1st, 2027. We will correct that date at the top.
Cheryl, if I may say that the date is accurate because the ICPA contract expired.
Okay, right. Not the I got it. Thank you. I was looking at that, wondering. That's it. Any questions regarding the procurement process, our timeline, and the summary? Thank you.
Ed or Sherelle, could you just clarify those dates? Because I'm not sure it was clear why one is from April and one's March.
Okay, so with Carosoft, they have an agreement with Salesforce. That agreement will cover the April 1st, 2026 to April 1st, 2027 for the ICPA, which we use that ICPA as a vehicle to use their software. And so the two differences, one is for the interpurchasing agreement and the other one is actually for the task order agreement. Yeah. Any questions?
Any other questions?
Oh.
Otherwise, I mean, I'm happy to do these two together. Do I have a motion for, it's 5 and 6?
So moved.
Thank you, Yvette. The second?
Second.
Thank you. All those in favor?
Okay, thank you.
Thank you.
Any opposed?
Just for clarity, this is motion 6 only.
Oh, motion 6. Okay,
Michelle,
guys have it.
it's not motion 5. You're on mute.
Motion 5 is for the language line.
The language line, that's coming next.
Thank you, Madam Secretary.
Sorry, that was flipped in the agenda. So, okay, so Venkat, back over to you.
And actually, I think now we're going to go to Tamara for the language line not to exceed amount increase.
Thank you, Madam Chair. Thank you, Michelle, for allowing me to present today, and thank you to the board. This request is for the board to approve a increase for the not to exceed amount for fiscal year 26 for language line services. And the increase will be $1.2 million for fiscal year 26. Next slide, please. Just want to give some history and some background on the language line. Language line services is a state contract. It's a 5-year state contract with this year for fiscal year 26 is an option, not an option, but extension year that the state added on. It ends at the end of 2026, June 2026. Each agency issues its own purchase order through the state contract, and the language line remains the most cost-effective and comprehensive option available for MHBE in the state of Maryland at this time. Next slide, please. On an average, the language line handles about 70% of its calls is in Spanish, French, and Amharic, and Haitian and Creole is tied for second. Again, the language line gets its best pricing. We did try to go outside and look for pricing, and this contract under the state's contract was the best pricing that we could find. This language line offers 250 different languages. Next slide, please. Just want to give you some history on the funding and how much we've spent. If you look at year one, the contract not to exceed amount was $250,000. We actually spent $221,000. And if you look for year two, it was also during the pandemic, and we had a not to exceed amount of $250,000, and we spent $290,000. Going to year at the bottom, year 7, which we're in now, it shows that not to exceed amount for $250,000. We have already exceeded that by $382,000. Next slide, please. This slide, I know there's a lot going on in this slide, so my apologies, but it kind of gives you the overall on from July of 24, how the spike up and the amount that the amount of calls, and also the amount of money that the charges for the calls and the amount of minutes. Any questions on this slide? Next slide, please. And this
Sorry.
slide right here, I'm sorry.
All right, yeah,
Hi.
I'm sorry. Is there anything you can say about, I mean, do you have any theories about what was going on? I know.
I do, and I was
like
going to get to
eligibility
that. Yes,
for the
ma'am. Yeah,
okay.
I was
Was that
definitely going to get to that, but I
okay.
can get into it right now.
Okay.
So, you know, due to the state of the nation, individuals are not going in person to local offices. They're calling. You know, there's nothing we can do about that right now. They're calling the call center. They are calling the CEs. They're also calling MHBE offices. So we are getting those individuals. They're just not coming into the offices right as we speak. And as you see, the outlier here is Spanish speaking consumers that are definitely using this service. Any other questions on that, Joanne? All right, thank you so much. This slide right here, just want to go back to this slide. This slide definitely shows the increase in the amount per month that we were paying. And if you look at it, I mean, it just shows that it went from one thing to another thing just instantly within a matter of 3 months. So it went from 87,000 to 96,000 to 122,000. And that's just over a 3-month period. Next slide, please. So the language line, the services from October through December is when we noticed the spike. 89% of the calls are Spanish speaking consumers. 61,881 calls were made directly to our call center vendor, Maximus. And just for this, we have tried to put some things into play to see if we can't try to lower some of this cost. And we did have our contract with Maximus, we had the bilingual staff at 38. We now have increased that to 51 to try to help bring down some of that cost. Next slide, please. And here's just a synopsis to tell you versus Medicaid versus QHP. Most of the calls that we're getting for the language line from October through December is Medicaid calls. QHP calls have increased a little, but that's only because of open enrollment right now. Next slide, please. Again, this just gives you a scenario about the Spanish calls versus non-Spanish volume, and it's 89%. Non-Spanish calls are approximately 11%. Next slide, please. So calls per minute. We are noticing that the calls per minute have definitely increased. Individuals are staying on the calls longer. Billed Spanish calls grew by 32% from November to December. And that was definitely driving the cost higher because we do also pay by the minute. Actual Spanish calls also increased over 28% over just 1 month. The language line cost rose by 23.3%, just in 1 month. Next slide, please. And this gives you a synopsis, just to tell you like the languages that are getting the most volume. And as you see, it is Spanish still leading the way of getting the most calls. And I will definitely contribute, going back to what I just said earlier about the state of the nation, and that individuals are just not wanting to go into the office because they don't feel safe. Next slide, please. I'll turn over to you, Madam Chair, for the motion. Thank you.
Yeah, thank you, Tamara, for the presentation. Are there any questions? Do I have a motion?
So move.
Thank you, Yvette. A second?
Second.
All those in favor?
Thank you.
Any opposed? Okay, ayes have it.
Thank you, Madam Chair.
I think that brings us to the end of our open session. So can I have a motion to meet in closed session to discuss personnel matters that affect one or more specific individuals pursuant to general provisions, Article 3305B1?
Chair Sassamani, we have a separate call-in session.
Okay.
We have to.
Do I have a motion?
So
So
moved.
moved.
Second.
Okay. Okay, all those in favor?
Thank you.
Great. Well, thank you so much, everyone. Michelle, anything else you'd like to say before we disconnect?
Thank you. We'll just keep you updated on what we're seeing in trends with enrollments and people not effectuating. So I'll keep the board updated on that. Thank you all.
Thank you.
Thank you, everyone. Have a good day.